Now regarding now regarding the periodontal prosthodontic integration, as you know, active periodontal disease must be treated and controlled prior to any restorative dentistry. Also, restoration should be on periodontum that is associated with good aesthetic function. Sharma and his colleagues in 2022 reviewed several periodontal prosthetic factors that should be considered during treatment planning, designing the fixed restorations, and management of compromised cases. These include gingival level and contour, edentulous area, pontic design, size, amount of periodontal support, abutment tooth preparation, and prosthesis morphology in terms of contour, proximal contact, and furcation. In this seminar, we're going to talk about the first one, gingival level and contour, mainly because it involves the most of the periodontal procedures. You know, as a prosthodontist, we should ideally follow the gingival contour, not exceeding the 0.5 from the base of the sulcus. Also, it has been recommended that at least 3 millimeter of sound tooth structure should be preserved between the prosthesis margin and the alveolar bone, considering the biological width. And if we violate these numbers, this might lead to increase in gingival inflammation, attachment loss, and gingival recession. So, there are several periodontal procedures that can modify the gingival contour. They can be classified in two main categories. First category is a subtractive category, which usually use more than the additive methods. They are more predictable and they are simpler. You simply cut the soft tissue or the bone, and we have the additive techniques. And of course, the choice would be affected by several factors such as aesthetic, hygiene, and biomechanical requirements. First group, the subtractive techniques, mean that increasing the clinical crown length by removing soft tissues with or without osseous modifications. Usually indicated in first, physiological biologic width, in case where fracture line, perforation, or the restorative margin are located subgingivally. Second indication for short clinical crown, which is less than 3 millimeter, which is associated with poor resistance and retention forms. Third indication would be the elimination of periodontal pockets, and the fourth indication is to increase the tooth display and resolve the uneven gingival contour. Regarding the disadvantages, they might increase root sensitivity, jeopardize the crown root ratio, and in turn the mobility. Second is when several teeth are involved, there will be a risk of loss of interdental papilla and development of black triangles. Again, during the tentative plan, we should allow as possible 5 millimeter from the contact area to the bone. And the third disadvantage is crown lengthening teeth, more susceptible to recession, furcation involvement compared to the control teeth. The three main methods used or that considered subtractive technique are the gingivectomy, which means there would be no bone to be removed, apically positioning flap with osseous reduction, and the third one, forced eruption combined with surgery or combined with fibrotomy. Gingivectomy, as we said, no bone removal, indicated usually in cases that associated with gingival hyperplasia. And as you can see in this figure, this line show you how much enlargement occurred in the gingiva. The landmark that we use in order to contour the gingiva in these cases would be the cement-enamel junction. Regarding the later prosthodontic treatment, as long as there would be no root sensitivity or signs or symptoms on the tooth, there would be no, the prosthodontic procedure or the prosthodontic coverage wouldn't be necessary, such as root sensitivity. Second, apically positioned flap with osseous reduction. As you can see here, we have these two familiar scenarios. The top two figures show you the functional crown lengthening. In the functional crown lengthening, where the aesthetic is less important, here we do the preparation until the final finish line, and the periodontist would be guided by this finish line uh, during the process of crown lengthening. On the other hand, the bottom figures, which show you the aesthetic crown lengthening, as you can see, here we do the crown lengthening procedure and wait for the biologic weight to take place, maturation for the gingiva, and achievement of good architecture, which usually takes about 6 months. Then after that, we can do the preparation for the teeth if needed. The third one is false eruption combined with surgery or combined with fibrotomy for isolated cases or localized anterior subgingival defects, or in other words, that in cases where crown lengthening alone is not enough, false eruption is not enough, we need both. This is an example. You can see top left figure. This is the first step. They do the fibrotomy first in order to facilitate the forced supraeruption. Then they do the forced supraeruption, as you can see in the top right figure with brackets. If there is any remnant discrepancies in the gingiva that jeopardize the level of the gingiva, we can further remove it by the crown lengthening procedure, as you can see in the left bottom figure. And the remaining figures show you the end result. So this is an important part, as a part of current topics. This is an important part. How to plan for subtractive techniques. This is accomplished with either diagnostic wax-up alone, either diagnostic wax-up, either bone sounding, the conventional that we know, or combination of both techniques. As you know, in the conventional bone sounding, we use sharp instrument and local anesthesia. The sharp instrument and the local anesthesia would be inserted in the soft tissue, labially and interproximally. In this way, we can evaluate the thickness of the soft tissue and, of course, the proximity to the underlying bone. This is the conventional technique. But as you can see, as you notice here, the conventional technique has two disadvantages here. The first one being invasive technique, and the second one, this technique or the conventional technique can detect any internal defects such as dehiscences or fenestrations. So this advancement or the advancement of bone sounding solve the problem of invasive procedures and internal defects detection. The way how it works is the following. First, they scan the upper or lower arch, intraoral scanning, then they get an STL file, of course. Then another scan using CT or computed tomography for the same arch. This scanning will be as DICOM file. This DICOM file have to be transferred in format into STL file in order to be superimposed with the intraoral scans. So we use softwares in order to superimpose the CT scan and the intraoral scans, as you can see in this figure. In this way, the digital wax-up can be designed in a way can define or locate the desired or the intended or the final gingival margin that, of course, accommodate with the appropriate biological width. You can see this technique is a non-invasive technique, three-dimensional, can also, because of the computed tomography, can detect internal defects such as the dehiscences and fenestrations. So let's talk about it in details. Passos and his colleagues in 2019 describe a full workflow that involved digitally guided surgical guide designing and fabrication. This is a brief workflow for you. We'll talk about it in details. First, as you can see, this is the intraoral frontal view. First, make intraoral scans for both arches and, of course, the occlusal relationship. In this case, they used the Seric OmniCam system for the scanning. Second, before they determine the level of or determine the final level of gingiva, they create a diagnostic setup, design the teeth and their form, printing a digital mock-up from, as you can see, printed mock-up from the design. And if the patient happy with it, we can proceed. You can proceed with the final position of the gingiva or the bone. So the patient happy with the mock-up, then we proceed to the CBCT scanning, as you can see, past here. And in this paper, they use the software, Autodesk Mesh Mixer, in order to superimpose the intraoral scan with the CBCT scan. And the bottom figure, you can see the digital bone sounding. This is the real digital bone sound, how it looks like. In this bone sounding, as you can see, you can determine the amount of bone removal, whether in the first place you need bone removal or not. From this bone sounding, you also can determine, as we said, internal defects, proximity of the bone to the bone. And finally, designing the surgical guide. And then printing the surgical guide. And this is how the surgical guide look like, whether conventional or printed. This is how the surgical guide look like. Usually involve the parts of the tooth, cervical part of the tooth, and involve the area that is to be cut or removed. Then proceed with the crown lengthening with the periodontist. The second group are the additive techniques. From its name, correcting the gingival level and contour by augmenting the gingival tissues and reducing the height of the clinical crown. Indicated when there is a need for improvements in the dentogingival aesthetics by increasing the width of the attached gingiva and to alleviate dentine sensitivity. Involve three main techniques, which are the free gingival graft, the connective tissue graft, and coronally positioned flap. However, the use of additive techniques should be restricted to confined recession lesions where an adequate blood supply is available. So if there is no enough blood supply, don't do it. First one is pre-gingival graft, which is the most commonly used technique. Usually used for denuded root surface area. As you can see, the primary root coverage here occur due to the existing vessel of the graft. But the problem with these kind of grafts are the look of it. They look like a scar because of the color mismatch between the grafts and the adjacent areas. The second type, which is the second technique, which is a connective tissue graft, usually a subepithelial connective tissue graft. This one has two special advantages. First, the double blood supply, and the second advantage is that they contain genetic information, which means if some parts that are denuded or uncovered or isolated area or defects that are uncovered, these grafts can encode this information in order to form layerings and cover these defects, which is not exist in it's not associated with the gingival graft, this advantage. And the most tolerable one is the coronally advancement flap. You use advance a flap from an adjacent area to the denuded root surface. Here we don't need to go for the palate and take a piece and graft it into the denuded area, which means less morbidity for the patient, which means better healing. But it doesn't work in all cases, only work in small gingival recession, isolated gingival recessions. In the review, they recommended that in order to close recession areas, shallow recession areas, you need at least 1 millimeter apical to the root exposure, and you need 2 millimeter for recessions that are 5 millimeter wide. And of course, as any flap, the thickness would be important in order to avoid the risk of torsion. We'll talk briefly about this part, the guided regeneration, which means the process in where the regeneration of lost structures is sought via selective cell and tissue repopulation, which means allow for special type of cells to repopulate and hold some cells not to populate or migrate or do their work. Here, they divide it into the guided bone regeneration, as you know, and the guided tissue regeneration, both indicated in cases with fenestration and dehiscences to fill the internal defects, building up bone around implants placed in tooth sockets after tooth extraction, socket preservation for future implantation, sinus lift, and repairing bone defects surrounding dental implants caused by peri-implantitis. This is a very huge subject. Now, next topic, the endodontic part. I will talk also briefly. I will talk about a review that's conducted by PUVA in 2020. They reviewed clinical both and laboratory studies in order to find out if there is prosthetic recommendation that should be considered with endodontically treated teeth. They reviewed several factors such as Farrell effect and number of remaining walls, residual tooth volume, tooth location and proximal contacts, timing of the cuspal coverage, cracked teeth, indirect restoration material, post roots, and finally endocrowns. So that's what they did. They reviewed papers, and these are the conclusions regarding the Farrell effect and number of remaining walls. Concluded that there is an improvement in the fracture resistance of teeth with increased supramarginal tooth structure. Also, the number of residual walls appear to be relevant to the survival of the root teeth. Those with no or only one residual wall appear to reduce survival rates when compared to teeth with more than one wall. And these conclusions were drawn from laboratory studies. Regarding the clinical studies, the results were less definitive. Regarding residual tooth volume, the clinical studies that assess the volume of the residual structure suggested a strong correlation or relationship between the remaining tooth tissue and survival. They concluded that for root-filled teeth, particularly those undergoing root canal retreatment, when the residual tooth volume is less than 30%, there is a higher risk of endodontic failure. Third factor, which is the tooth location and proximal contacts, they concluded that the more the proximal contacts, the better the survival of the root-filled teeth. They found that teeth with two proximal contact associated with highest survival rate, lowest survival rate associated with no proximal contact, and one teeth that have one proximal contact in between have survival rates in between. The fourth one is the timing of cuspal coverage. Suggests the enhanced survival rates for posterior teeth restored exponentially with cuspal coverage restoration following root canal treatment, which is a good thing here. They also suggest that delay of only 4 to 6 months may have a negative effect on survival of root-filled teeth. Regarding the cracked teeth, survival rate of cracked teeth appear to be high. In direct restorative material, the long-term performance of gold crowns appear to be very high based on the retrospective studies. Also, all the available evidence indicated that restoration of posterior teeth using materials such as ceramic crowns, inlays and the crowns are as durable as metals, which is a good thing. And regarding the indirect composite restoration, there is limited evidence. Posts and roots. Most studies restrict the restoration of root-filled teeth without post to teeth with at least 2 remaining cavity walls and demonstrate high survival and success rate. Also, biomechanical consideration lead to assumption that posts are more frequently needed for the maxillary anterior teeth due to the higher risk of mechanical failure in this region. This is an important one. An adequately performed adhesive luting procedure, including a clean and adequately dried dentine surface, seem to be more important for the success of coronal restoration of root-filled teeth than specific bonding protocol or luting material. And finally, teeth restored with fiber posts have comparable survival rate to those restored with direct or indirect metal posts. Regarding the crowns, there's limited evidence, but it might be concluded that it might be a suitable alternative to restore root-filled molars if the adhesive luting procedure performed appropriately. Now, what about vitality? How vitality affects the strength of the abutment teeth, endodontically treated abutment teeth or vital abutment teeth. Abisha and his colleagues in 2024 conducted a systematic review and concluded that endodontically treated abutments are not favorable for longevity survival of fixed partial dentures, and they present with more risk of hazard and complications. Therefore, vitality of the abutment should not be sacrificed unless there is a questionable pulpal or periapical diagnosis perioperatively. Now, for special consideration regarding the endoprosto treatment, in cases of root resorption, perforations, or other endodontic challenges. As you know, internal root resorption diagnosed incidentally, which means they do not cause any signs or symptoms, usually asymptomatic, and usually discovered at late stages where the tooth at that point may indicate extraction. The use of mineral trioxide aggregates in an association with pipeline porous dowel has been reported to fill the resorptive spaces. And of course, what the main determinant for the prognosis of these kind of teeth is the location, the size of root perforation, the close proximity perforation to the gingival sulcus, which might lead to the contamination of the perforation area and thus create pathologies. This case, about 42-year-old female patient complaining about aesthetics of her smile, was referred for prosthetic rehabilitation of her anterior teeth. She reported no pain or discomfort. Again, the main complaint was aesthetic, not this incidental finding of resorption or perforation. Reported no pain or discomfort associated with her anterior teeth. Upon clinical examination, the routine clinical examination, poor obturation was found, and irregular radiolucent lesion in the middle third of the maxillary right central incisor. This is the CBCT, show you that there is internal root resorption, and there is also a perforation at the mid-buccal third that cause a communication between the canal system and the PDL space. The initial treatment plan was to do the endodontic treatment for all anterior teeth. Of course, retreatment in for the teeth that need retreatment, and treatment for the teeth that are primary lesions. And the second thing in the initial treatment plan was to do the aesthetic crown lengthening. So the first stage was to do the endodontic retreatment. They use here the lateral compaction technique. The resorptive areas filled with gray MTA, as you can see here. This is the MTA. After the endodontic treatment and retreatment was done, diagnostic wax-up was done and used to preview the aesthetic effect and to see what is the real, or what the final result would be. According to the surgical wax-up, according to the diagnostic wax-up, mock-up was done for the patient. The patient was happy. Then, according to the diagnostic wax-up, the surgical guide were fabricated for the crown lengthening, for the aesthetic crown lengthening. But in this case, the crown lengthening has two purposes. The initial purpose, which is the aesthetic crown lengthening, and the second one, which is they created the incision apical to the position of perforation in order to do curettage and remove the granulation tissue. So in this case, it has two purposes: the aesthetic crown lengthening and the curettage for the granulation tissue. After that, after removing the granulation tissue, the area of perforation that was exposed after removing the granulation tissue filled with MTA. Then the flap sutured, and the patient was asked to come back 1 week after for suture removal. This is 5 months after endodontic treatment and 4 months after the surgical crown thinning. Now there is initial, as you can see, there is initial sign of healing, regression for the periapical lesions. They started planning for the prosthetic phase, which is, of course, start by doing double post anchor for the anterior teeth. All the anterior teeth were planned to have a metal post, except the central incisor with the perforation. They plan to do fiber post, fiber reinforced post. And they optimize the treatment outcome by doing three things, three tricks. First, in order to minimize the amount of film thickness, the cement film thickness, they kept filling the canal space with several posts in order to reduce the amount of the cement thickness. Also, they sorry, I said fiber post, not fiber post. It's indirect technique, because with indirect technique, you would have better fit than a prefabricated post. In this way, they also minimize the amount or the thickness of the cement in order to achieve as strong as possible post and core system. This is composite build-up, and the restoration was planned as zirconia core and Emax veneering porcelain. This is the final result. And this is the key for the success for this case, which is the follow-up. The follow-up, which is the most important part of this case. You see, after 9 months, there is sign of healings. So sign of healing. Almost there is no, I know it's panoramic radiograph, but clearly there is a sign of healing. Further sign of healing or at 15-month follow-up. All right, this is the final part, the last part. I will talk briefly about this platform, which is called the cloud-based collaboration platform for remote case consultation. Okay, just give me a minute. So, cloud-based dental software revolutionized the way dental team collaborate for several reasons. Effortless appointment management, because they automatically can schedule, modify, track appointments with ease. Integrate telehealth services, such as integration for virtual consultation. Comprehensive patient records. They can centralize patient data securely, enable accurate diagnosis and personalized treatment plans. Intelligent billing and invoicing, which means simplifying the financial processes with automated billing cycles and flexible payment options. And of course, enhancement of the enhanced communication tools, compliance and reporting capabilities, and continuous training and support. All of these are advantages of this new platform. I'm going to show you this video. What you're going to see in this video is an example to show you how everything simplified. It's simply like the Microsoft Teams that you're familiar with. You can form a group of employee, in our case, group with technicians or other specialties. You will see how they chat, they react, consult each other, and at the same time design the restoration. You will also find that in this video, smart design based on video. which is, of course, give you more information than the two-dimensional smile design. Okay, I'm going to play it. This is the chat box. The three-dimensional smile design.